the social circumstances in which it happened, not in villages that could be isolated and quarantined and an epidemic brought under control quickly, but in major capital cities and across borders. And that more frequent and indeed sociologically more complex epidemics and pandemics is what we will face in the future.
Does it follow, Sir Jeremy, that from the vantage point of governments and with a view to the necessary and important process by which risks are identified, assessed and planned for, that there must be a much greater focus now, both in light of COVID and, of course, because of the increased general risks to which you've referred, upon firstly identifying multiple scenarios as opposed to just influenza. Secondly, focusing additionally on how to prevent catastrophic consequence as opposed to managing catastrophic consequence. And thirdly, thinking more and to a much greater extent about the necessary countermeasures that may need to be deployed.
Yeah, absolutely. First thing I'd say is what you have before a crisis hits will, to a large extent, determine your ability to respond to it. If you have deep inequalities in your society, if you have a large degree of ill health in terms of health issues, if you have health services which are stretched to the limit, if you have fragmented government approaches such that each individual vertical structure considers its area, but there's a challenge to sort of look at the all of society perspective, then trying to cobble together a horizontal approach, an all of government and all of society approach in a set of vertical systems is extraordinarily difficult. And tabletop exercises will get you so far, but you need to be working in those systems all of the time if you want those systems to work when a crisis hits. And I think we need to think more strongly about how totally disruptive all of society events, of which this is a good example, will be dealt with at a cross-government whole of society approach rather than just as a single ministry approach.
A vital component in the whole of society approach is, of course, having adequate scientific advice, as well as, and alongside, a adequate and sufficient research base. Could I focus firstly, please, on the issue of the scientific advisory networks which are available in the United Kingdom? You were a member of SAGE, the stand-up, that is a committee which is stood up in the event of emergencies in relation to Zika and Ebola. Is that correct? Have you had extensive experience throughout your long career of dealing with the scientific advisory structures in the United Kingdom beyond SAGE?
Yes.
Evidence was given by Professor Sir Chris Whitty that the UK science advisory system, whilst complex and not perfect, is considered to be one of the stronger ones internationally. Would you agree?
Yes.
What must be done to ensure that that remains the position in terms of resourcing or funding or a continuing focus on understanding the vital importance of scientific advice?
So I would agree with those comments, and I've been involved in some of your introductory remarks with a number of other governments around the world of all economic levels of growth and depth of scientific background. My view is that the construct of having a chief scientific advisor in every ministry, close to the minister, close to the system, close to the senior civil servants, not just structured in a crisis, but there every day, and learning to bridge the cultural and language complexity that is there within different disciplines and different ways of working and different educational backgrounds and everything else. building that structure to be permanent, to be functioning all the time, and critically providing value and utility to a government machinery all of the time is, I believe, critical. And I've argued with many other countries, discussed with many other countries that actually the UK system of scientific advice in every ministry brought together under a chief scientist, networked together, providing mutual support to each other, is absolutely critical, must be maintained, must be strengthened. The very best people in science should be encouraged to go into it and on a rotational basis so that they can retain their scientific expertise and skills and then network together through the chief scientist. That, to me, is the best system in the world and everything should be done to maintain it, not for crisis time, but for all the time, to deal with the day-to-day issues as well as be able to respond when a crisis inevitably hits.
It's plain, Sir Jeremy, that in the particular context of dealing with the COVID pandemic, SAGE and the scientific advisory structures in the United Kingdom government drew to a very large extent, of course, upon biomedical expertise. Because of the need to consider at speed and in very difficult circumstances that the consequences of societal measures, social restrictions, mandatory quarantining and so on and so forth, it may be the case that there was an absence of sufficient expertise from non-biomedical professionals, that is to say, economists and behavioural scientists or social scientists and experts, not from the world of health and not from the world of science, but from the social sciences. Would you agree with that? From your experience of SAGE, do you think that it is, in a general sense, sufficiently diverse?
So I would agree with some of that, but not all of it. Firstly, I think that SAGE is often seen as the names officially on the SAGE list, which I think counts to 30 or 40 people or so. Behind that, there were hundreds of people involved, and particularly on some of the areas you mentioned there, behavioural science, for instance. I think the input into the behavioural scientists into SAGE throughout my time on SAGE, I thought was of the very highest quality. Where I do agree with you is that there were two things lacking in my view. One is the SAGE health, public health, behavioural science perspectives on the pandemic were not mirrored with other equally transparent and debated issues that brought the whole of the society elements together. And I believe, I've never been in government, but I believe that a better approach would have been to have a SAGE that focuses on its area of expertise, definitely including behavioural science, international perspective, ethics, many of the things you mentioned. But that would be mirrored, in my view, through the Cabinet Office with a similar transparent expert group that would consider other aspects that are absolutely critical to an all-of-society response. I think if you ask SAGE to do all of that, it would become huge, unwieldy, and wouldn't be able to have the clarity, given in mind that SAGE was meeting at some point every 24 or 48 hours. So personally, I would do that through the Cabinet Office, but have equal transparency with elements that considered other aspects beyond the health agenda. And the second thing I would suggest, and I was part of this in a US group, is that there is outside the SAGE system, but linked to it in a constructive way, if you like, a red team. A red team that would have access to the same information, but would be able to constructively challenge the thinking from the outside and wouldn't be within the room at the same time. I thought that worked extremely well when I was part of a similar enterprise in the United States. And I would like to see that set up. Independent SAGE, I think, tried to do that, but unfortunately, for reasons others can debate, sometimes it became more confrontational than perhaps was constructive.
A red team would plainly be in a position to challenge orthodoxy. Do you mean orthodoxy on the part of the government or orthodoxy or alleged orthodoxy on the part of the scientists in SAGE or a mirror group, who I think I should tell you have described themselves in this inquiry in various terms, such as being self-correcting or, on another occasion, as being licensed dissidents. Do scientists need to be challenged in that way, or is this a point made more directly against administrators and government employees?
Science absolutely has to be challenged, and I think, unfortunately, I'm not aware that beyond the summaries then released, I think at the behest of Patrick Vallance, crucially. It's a shame that actually SAGE wasn't recorded in some ways, because I think within the SAGE discussions that I was always part of, there was a very high degree of challenge. But to have an outside group, a red group, that just puts in questions, have you thought about this, have you thought about that, have you considered that, who are not part of that formal group, I think my own experience of that is from the United States, and there I thought it was very helpful to be able to do that. It doesn't diminish the authority or the voice of SAGE, but it would give you some of that external challenge. I think within the Cabinet Office, to me, that is where the political challenge of is this the right thing to do, closing schools, closing economies, whatever it might be, should be held. But I think those need also to be transparent in the same way that SAGE was with its minutes and summaries, so that people can actually, as the public, can actually challenge those assumptions as well.
All right.
Mr. Keith, are you going further into the mirror group?
No, I was going to move to the question of specialist committees.
I just have a brief summary of what Sir Jeremy means by the mirror group, which experts, how would it work?
Yes, so Sir Jeremy, a few moments ago, in response to a question from myself as to whether or not the constitution, the makeup of SAGE was sufficiently diverse, you suggested the possibility of a mirror group, not as part of SAGE itself, because it would become too unwieldy and too large to be convened at speed and in very difficult circumstances, but a separate committee comprising experts, specialists from different professional walks of life. Could you expand on that? You referred to social scientists, economists, and others. Is there anything more that you want to say about that in terms of its composition?
Well, I think the social scientists and behavioural scientists were absolutely fundamental to SAGE itself. So I certainly, but I think a group outside of what I call a red team that was able to throw in questions into SAGE. Have you thought about this? Have you thought about that? Some of that happened informally through things like in the UK, the Royal Society, Academy of Medical Sciences, etc., and obviously in the lay and scientific literature. But I, having been part for some time in the US of that red group, which brought together, yes, epidemiologists, biomedical people, social scientists, economists, people thinking outside the box, that was helpful, I think, in terms of the US approach to this, which I have to say, I believe was not as well constructed and organised as was SAGE, would be my view, having seen both operating.
So those specialists and scientists and professionals are, in terms of their own professional qualifications, mirror images of the constituent parts of SAGE. They're not from other walks of professional life. That they are there to challenge, if you like, the members of SAGE on their own turf. No,
I wouldn't. No, sorry. Let me clarify. I think in that sort of red group, you could easily have a broader sector of society, civic society, industry, people, yes, with expertise and understanding of public health, but also others who would bring a different perspective.
Right. So, Jeremy, can I ask you now about your experience, please, of some of the more specialist scientific committees concerned with pathogenic outbreaks? Have you had dealings over the years with HARES, the Human Animal Infections and Risk Surveillance Committee, or ACDP, the Advisory Committee on Dangerous Pathogens, or on the now abolished NEPNI? Are those committees, although you weren't in government, with which you've had any experience?
No, I was not part of any of those. The greater experience I had was actually outside the UK, as you mentioned, being the founding chair of the WHO R&D Blueprint advisory and WHO committees and the other governments, but I was never involved in any of those that you mentioned there.
All right. You've referred in the course of your evidence to the growing risks of pathogenic outbreaks, particularly of the viral respiratory kind, and to the growing risks generally because of changes in our environment and our way of life. To what extent is it essential to meet those continuing and growing risks that we maintain as a country capability, that is to say, the medical, scientific and social weapons at our disposal to meet a future pandemic?
So I started off by saying what you have before a pandemic or any crisis hits makes such a huge difference. There are many things to question and challenge, and that's the role of the public inquiry in terms of the pandemic. But I think we can only celebrate the remarkable scientific, and by scientific I mean the broad sciences, contribution to the pandemic in the UK and around the world. That you can't turn that on in a crisis. We didn't make a vaccine in 12 months. We made a vaccine because for years before, all governments in the UK of any colour, I would argue as well, the Wellcome Trust, the charitable sector, philanthropy, have invested in basic science, in people, in teams, in institutions. And if you look through the development of the Oxford AstraZeneca vaccine, if you look at COG UK, building off years of work at the Wellcome Genome Centre, if you look at the recovery trial, if you look at when local authorities and others through public health got involved in their communities through ownership and knowledge of those communities, those were absolutely world-leading. Those are the results of decades of investment in fundamental science and its translation. A brilliant regulator. MHRA now, and when it was part of the EMA, is one of the world's, if not the world's best regulator. They were critical, understanding ethics. So this infrastructure in the UK is something the UK should be incredibly proud of, must maintain, and has a critical role to play internationally.
Is that a capability without which it is impossible to scale up the necessary medical and clinical responses in the event of a pandemic? Is that something which must be maintained, because without it, we would not have the building blocks to be able to mount a defence in the event of a pandemic?
Absolutely agree with that. As I say, the vaccine was not made in a year. If you don't maintain that capacity, and if that capacity isn't valued, isn't funded, is not providing value and utility all of the time. We should remember that the Oxford AstraZeneca vaccine came off a team, Sarah Gilbert, Andy Pollard, and many others, have been working on MERS vaccines, they've been working on typhoid vaccines, they've been working on meningitis vaccines, and were able to pivot. The recovery trial built off years of investment, particularly from the National Institute of Health Research and the clinical trials capacity. These are absolute jewels in the UK's crown. They could play, in my view, a bigger role internationally, but you have to maintain them every Monday, every Tuesday, and you have to value them, and they must provide value either in enhancing knowledge and our understanding of the world, or in translation into products, countermeasures for people in a pandemic. If we do not retain that scientific infrastructure, then the UK will be woefully underprepared to deal with today's challenges and tomorrow's inevitable epidemics.
Does that infrastructure include matters such as having sufficient laboratory services, for example, to be able to scale up mass diagnostic testing in the event of a new pandemic and perhaps a different testing device. What sort of laboratory infrastructure is required to be able to provide that building block to enable us to scale up in the next crisis?
The testing capacity in the first 3 months of 2020 in the UK was woefully inadequate. It wasn't possible to scale that up at the speed that was required, and testing got way behind the speed of the epidemic. And in epidemics and pandemics, there is no point saying we're quicker than we used to be if you're slower than the speed of the epidemic. And if you get behind that curve, you'll really struggle to catch up. Remembering that exponential growth, doubling time every 2 days, means even 48 hours later, you've got behind the curve. And the data you have today is in the rear view mirror. It's what happened yesterday that you're seeing, not what happened today. So unless you have that diagnostic capacity, I would personally like to see a much closer interrelationship between what we call public health laboratories, clinical and NHS facilities, and the broad and very strong research environment in the UK. Often these are almost competing with each other rather than seeing themselves as part of a common approach. And I think to forge together public health laboratories, local authorities, hospitals and clinical facilities, general practice, primary care, and the research endeavour, and make sure that those are working together outside the pandemic and can much better work together in a pandemic, would be a huge progress in terms of our ability to have the resilience in the future.
So drawing those threads together, Sir Jeremy, would you agree that both in terms of research capacity, but also infrastructure, laboratories, technicians and the like,
yes,
it is vital, I'm sorry, I haven't quite finished. It's vital that capability is maintained for both, for not just diagnostic testing, but antivirals and also vaccines, to which you've referred. So this is a capability which must be maintained across the board for those three pillars, if you like, of pathogenic outbreak response.
Yeah, I would actually add to that. The social science, the behavioural science must be integrated as part of that, not some separate thing that goes on in other conversations. But we must maintain that all the time. The only way to maintain it, and if we're not to repeat the lessons of all of the epidemics I mentioned at the start, the only way we can maintain this is if it is integrated into services and health provision, prevention and treatment every Monday, every Tuesday, every week, every month. Because after every previous epidemic, after Ebola, the world said, never again. We must build these capacities. And sadly, 1 or 2 or 3 years later, the pandemic hasn't happened and they start to be cut. So my view is, instead of creating yet more vertical structures that will somehow be there when a pandemic strikes, build it into systems that are of use every day, people are using them, they provide value to communities, and then they can pivot when it's necessary. If we look at COG UK as a good example, established by Sharon Peacock, it was building off years of public health interest in genomics and the Wellcome Trust Genome Centre and institutes like the Crick, Edinburgh, Glasgow, Manchester and others, Biobank. These are critical infrastructures. They're providing value and utility all of the time, and they have critically the people who can pivot when necessary. We must not lose this capacity.
Turning now finally to a more administrative or governmental angle and the issue of countermeasures. Is it your view that further work is also required to be done in terms of thinking about, evaluating, working out the consequences of the policy interventions with which we're now all only too familiar, such as quarantining, social distancing, the efficacy of face masks, airport screening and so on, all of which, of course, came very much into focus during COVID, but perhaps have not been developed in terms of the thinking as far as they might be.
Yes, I do agree with that. And having listened to some previous interventions and the concern that everything was based around a potential flu pandemic and no other thinking, things I would say on that, flu remains the number one biggest risk. But we should be thinking beyond flu in terms of a crisis management system that would be agnostic to what the event was. And it could be respiratory, most likely. It could be sexual. It could be through the gastrointestinal. So there's all sorts of scenarios. And instead of getting plugged into a single outcome, which we feel comfortable with, perhaps more important is to think, whilst we will focus on flu because it's hugely important and is the highest risk, and it remains so, that nevertheless we must have a system which allows us actually to cope with whatever is thrown at us and have the resilience and the spare capacity and not the whole system stretched to its very limit in order not to be able to respond when the demand increases. So I would like to think more broadly, more like an incident management group than a flu-specific group, without losing the knowledge that flu remains a huge risk to us all. And those policy interventions that you talk about need a discussion at societal level. The word lockdown, none of us had heard of it before about February or March of 2020. The implications of it are huge and long-standing. We should be able to debate those in the inter-epidemic periods and come to a societal discussion about what we're going to prioritise, what we're going to protect, and what we may have to do in order to prevent an event like COVID-19 happening again.
Sir Jeremy, thank you very much. My lady, I believe you granted permission to Welsh COVID bereaved for an issue or issues surrounding the question of face masks to be explored through my own examination. Is that right? Sir Jeremy, could I return you please to the question of face masks? The issue of face masks and their efficacy is very much going to be a matter for consideration in my lady's module 2 in this inquiry, because of course there was a huge debate about face masks once COVID had hit. But in the context of preparedness, may I ask you this? To what extent pre-COVID was the wearing of face masks an issue which was thought about, sufficiently developed, and views reached upon? And an associated question, to what extent was there pre-COVID a scientific consensus on the efficacy of face masks, putting aside how effective they actually were? So, was there a standing scientific consensus on the efficacy of face masks pre-COVID, and to what extent had thinking on face masks developed pre-COVID?
Well, I think in the UK that consensus did not exist. And the effectiveness as well as the efficacy of face masks, I do not believe in the UK there was a consensus on that. Having spent almost 20 years living in Vietnam through SARS and H5N1, and then watching very closely and being very involved in the responses in China, in Korea, in Vietnam and Singapore, 4 countries that had previously dealt with SARS-1 and with other emergencies, I think if you ask there was a clear consensus amongst the decision makers and indeed the scientists and healthcare workers that face masks had a role in contributing to the public health intervention. In public health, there is rarely a magic bullet. Public health, the analogy of the Swiss cheese model of having multiple interventions is crucial. If you're expecting face masks to give you 95 protection against something, you won't get it. But as part of a series of interventions, which includes face masks, includes hand washing, and includes clean air and spacing between individuals, and then when you have the countermeasures you're talking about, diagnostic tests, treatment and vaccines, together they create a Swiss cheese model of how public health is. Each one contributes a percentage. None of them on their own contribute enough to change the dynamic of a pandemic, but together they can have a very profound impact. And when you talk about countermeasures, often we talk about countermeasures in terms of therapeutics and vaccines and diagnostic testing. But countermeasures need to be seen in the full Swiss cheese model. They need to include social distancing. They need to include masks. They need to include hand washing. They need to include in other epidemic potentials, other interventions, for instance, in HIV, condoms, etc. So I think we would be wiser, and the evidence base on face masks, unfortunately, whilst we had large clinical trials for therapeutics, the recovery trial, we had the vaccine trials, we missed an opportunity during the pandemic to gather robust, strong, prospective data on non-pharmacological interventions, which are a critical component of any response to an epidemic and pandemic until you have those countermeasures that will then change the course of the pandemic. So what I would plead for is we don't see countermeasures just as something you inject into somebody's arm or you take as a tablet, but we see countermeasures in a Swiss cheese model of public health, which integrates them all, and we find the evidence for how they work on their own, and we find the evidence for how they work together.
So, Jeremy, thank you very much indeed.
So, Jeremy, thank you very much indeed for your help. It's been extremely interesting, and we're very grateful to you. Thank you.
I wish you the very best with the public inquiry and offer all the support we can to it. The lessons must be learned, and we must never be there again.
Thank you.
My lady, I think that we can proceed to the next witness straight away. If somebody would be good enough to sever the link with Sir Jeremy, we'll return to the witness box.
Just before Sturgeon gives evidence, I'd like to apologise to those who were inconvenienced by the fact we didn't call Miss Calderwood on Wednesday morning. It was due entirely to unforeseen circumstances, and I can assure people we gave everyone as much notice as we could and as we got, in fact. So,
Lady, yes.
Apologies to anybody. Mr. Keith?
Could the witness be sworn, please?
Repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
declare
and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Thank you. Welcome.
Could you give the inquiry, please, your full name?
Nicola Sturgeon.
Ms. Sturgeon, thank you for offering your assistance and providing it to this inquiry. But whilst you give evidence, could you please remember to keep your voice up so that we may all clearly hear what you have to say, and also for our hard-working stenographer so that she can record your evidence.
Excuse me, my lady, with your permission, would it be possible to say a few words by way of introduction?
You may.
Thank you. I'm appearing at this public inquiry for the first time, and as the First Minister of Scotland for the duration of the pandemic, I wanted to take a brief opportunity to offer my sympathies and condolences to all those who have suffered as a result of COVID-19. The pandemic may be over, but for very many people that suffering continues to this day, and there is not a day that passes that I don't think about that. Secondly, I want to convey my thanks to all those who contributed to the national response, obviously to our health and care workforce, but to all of those across the public, voluntary and private sectors. And of course to the general public, who did everything that was asked of them and made extraordinary sacrifices. Finally, my lady, I know that every day the government I led did our best to take the best possible decisions. But equally, I know that we did not get everything right. The learning from the pandemic is of critical importance, and this public inquiry has a central role to play in ensuring that those lessons are learned, and therefore I appreciate the opportunity to be here before you for the first occasion today. Thank you very much.
Thank you, Ms. Sturgeon. You say the first occasion because, of course, it's known to my lady, but not necessarily the wider world, that you will be giving evidence again before this inquiry for the purposes of Module 2A, which will be the module that will be more particularly concerned with the response to the pandemic once, of course, it had struck. Ms. Sturgeon, you've provided kindly a witness statement dated, I think, the 19th of April 2023. We needn't bring it up, but it's a witness statement to which you have appended your signature and a statement of truth. Is that correct?
That's correct.
You were, of course, as you said, the First Minister of Scotland, but earlier in your career, you were Deputy First Minister and Cabinet Secretary for Health, and coincidentally, that was during the swine flu pandemic, which hit the United Kingdom in 2009. Is that correct?
That is correct.
And so you would have become familiar with the exquisite difficulties of dealing with the onset of a pandemic on a country and familiar with governmental response.
Yes.
Just to get our bearings, that pandemic, H1N1, as we've heard, was, by the general standards of these things, relatively mild, was it not?
Yes, indeed. Milder, thankfully, than any of us had expected at the outset of it.
There were some 1,500 hospitalisations in Scotland. Fortuitously, no deaths, I believe, but of course there were around about 17,000 deaths globally. There may therefore be a limit as to what lessons could have been learnt from that milder pandemic. But the Scottish Government commissioned a paper, did it not, to review its own response to that pandemic.
We did, yes.
And was that a report or a paper that you yourself commissioned?
Yes, I believe I would have commissioned that as Health Secretary at the time.
May we have, please, that paper on the screen, 102936. It's headed Cabinet Subcommittee on Scottish Government Resilience, Influenza H1N1 Pandemic Review of the Scottish Government Response, and it was a paper by the Cabinet Secretary for Health and Wellbeing. You were Deputy First Minister and Cabinet Secretary for Health, and therefore may we presume that was you?
I'd have to check the date of it to see whether I was still Health Secretary when that paper was produced, but I believe that would have been me, yes. Mm-hmm.
I think the paper was produced in 2011. You were Cabinet Secretary for Health until the 19th of May 2011.
I was Cabinet Secretary for Health into late 2012.
Yes.
That would have been me in that case.
Yes. You were Cabinet Secretary for Health until the 19th of May 2011, and then you became Cabinet Secretary for Health, Wellbeing and City Strategy thereafter.
Thank you for reminding me.
Page 5 of the report refers at the bottom of the page to planning assumptions. Respondents recognised the limitations of modelling. However, it was felt that it would have been helpful to have updated the planning assumptions more quickly to reflect the picture on the ground. in effect reflecting the most likely scenario rather than the worst case scenario. Respondents felt it would have been helpful for the process of testing the planning assumptions to be more explicit. The planning assumptions which were published did not hold much weight with responders on the grounds that they did not reflect what they were experiencing. Ms. Sturgeon, these references to the planning assumptions and to national and local responders' views as to how efficient or how useful that they were, was that a reference to the broad governmental system by which risks are assessed, grouped together, and assumptions made for the purposes of planning as to how those risks should be addressed?
So my reading of these paragraphs, and forgive me, I would need to see these paragraphs in the context of the whole paper to be certain that what I'm about to say is correct. But certainly in relation to the second bullet point there, what that seems to me to reflect is something that was certainly true in the handling of the H1N1 pandemic, is that the pandemic did not unfold in the way that the plans and the modelling and the reasonable worst case scenario estimates had indicated that it would. And that had relevance, I think, to what we learned about the strengths and weaknesses of pre-pandemic planning. So my reading of that is that that was a statement about the gap that opened up during the swine flu pandemic between what the plan told us would happen and what in reality happened.
That issue, the divergence between risk assessment, plan, identification of response, and the reality of a pandemic, was an issue that continued to bedevil this area of strategy planning, did it not?
Yes, it did. I think that is fair comment. I also, having now in different capacities, as we've been covering, been involved in the response to two pandemics, I, to some extent, think that there is an inevitability about that being a problem that will always exist to some extent, because there is no plan that will ever completely replicate what happens in reality when a pandemic, unfortunately, confronts us.
Indeed. And page 11, relatedly, in the middle of the page, there is this heading, actions to be taken forward as part of the UK-wide review into the influenza A H1N1 response. Was that a reference to the review which was carried out, in fact, by Dame Deirdre Hine?
That would have been a reference to the Hine review, yes.
We'll oversee the work of the review team through Scottish Government representation on the reference group. We'll consider the implications for Scotland of the emerging findings, specifically those relating to, and then the bottom bullet point, future iterations of the pandemic flu framework. Was that reference to pandemic flu framework a reference to the then pre-existing Scottish strategy for dealing with pandemic flu, and also the prospective, the anticipated United Kingdom strategy for dealing with influenza pandemic, which we'll come to in a moment?
Mm-hmm. So I suspect that would have been effectively both of those things. It would have been a reference to whatever pandemic flu framework was in existence at the time, the pre-existing Scottish Government one, and then what became the UK-wide pandemic flu preparedness plan in 2011.
Thereafter, Ms. Sturgeon, as Milady has heard in the course of evidence, under the Four Nations approach, the United Kingdom drew up and disseminated a new 2011 strategy, and that is, or became, the sole strategy for dealing with pandemics. And it was, of course, a strategy which on its face dealt only with influenza pandemic. There was a commitment there in that review by the Scottish Government to keeping future iterations of the pandemic strategy under review. But to a very large extent, that did not happen, did it?
The 2011 Four Nations plan was not updated. Now, for that to have been updated on a Four Nations basis would obviously have required the engagement of all four governments. In my view, and this takes us to the heart of some of the most important lessons I learned from the swine flu pandemic, had that plan been updated, I do not necessarily think it would have changed substantially. I think I heard Professor Sir Chris Whitty make a similar point to you last week. That a review, refresh, different iteration of that would not have changed necessarily the fundamental assumptions or planning or modelling at the heart of it. In brief, the two lessons that I took from swine flu in relation to plans were firstly, and I've already touched on this, the importance of any plan being adaptable and flexible when it first confronts reality. In summary, what happened in swine flu was that as the pandemic thankfully turned out to be milder than we had anticipated, there was a period when the governments tried to make the pandemic fit the plan rather than adapt the plan to the pandemic. So flexibility is the first point. The second point, I guess, relates to that, is the importance of whatever is on the paper in the form of a plan, that is work done to operationalise and test that plan. I'm sure we'll come on to some questions around exercise Cygnus on a UK basis, Silver Swan on a Scottish basis to a lesser extent, because it was looking at MERS, SARS rather than flu, exercise Iris. But the work that was done through these exercises and the work in Scotland that was done by local resilience partnerships sitting underneath our regional resilience partnerships, in my view, was more important than having tweaked versions of a plan that was only ever going to be a template for the situation that we ultimately found ourselves dealing with.
As it turned out, Ms. Sturgeon, the reality was that the plan, the strategy, the 2011 document required not just tweaking, and it may well be that it wouldn't just have stopped at tweaking had it been significantly revised. It was, and has been described by a variety of witnesses, as wholly inadequate, strategically. And do you accept that there is now a much clearer understanding as to the nature and the degree of the inadequacy of that document?
So yes, and if I may, I'll perhaps try to break that down briefly into two parts.
Please.
And perhaps give a little bit more explanation for my use of the term tweak. Had a process to update that plan focused on updating an influenza preparedness plan, I can't be sure about this, but I do not believe it would have changed significantly, because it would still have been a plan dealing with the potential for a flu pandemic. Had it been a process designed to turn a flu plan into a plan that was looking at a different range of pandemics, that may have been a more substantive exercise. In terms of your question, do I accept that the plan was inadequate? In summary, yes, the plan was for a different type of pandemic than the one we unfortunately were confronted with. What I would say in addition, though, is that does not mean no part of that plan was useful in any way, because some of the consequence planning for a pandemic, I mean, there are some, as we know, and we'll come on to no doubt today and in future modules, significant differences with significant consequences between flu and what we ended up dealing with in terms of a coronavirus pandemic. But some of the consequences were similar. So I would, I guess, push back a little bit against the notion that there was nothing in the flu planning that served us any purpose at all when it came to COVID-19.
You would accept, I think, that there was no plan for non-influenza pandemic, at least on its own face, correct?
That is absolutely the case. That is not to say that there was no thinking within governments around non-influenza diseases, high consequence infectious diseases. Exercise Iris, which was a Scottish Government exercise, looked at that specifically. What there wasn't, and I think this is the significant gap, is there was no set plan, which, as I say, is not the same as saying there was no thinking into how we dealt with a pandemic that had features and characteristics of flu in terms of transmissibility, but also the severity and what we came to understand in terms of the asymptomatic transmission of COVID-19. So if you look at Exercise Iris, it was looking at a MERS-SARS type incident, but not a pandemic, one that was small and very contained. Yes. So I would readily accept that there was a gap in terms of the pandemic we ultimately were dealing with. But as I say, that does not mean the plan that was in place had no utility at all.
No, and I'm not suggesting it had no utility. The plan on its face called for flexible application. It called for flexibility. It proclaimed the fact that viral respiratory pathogenic outbreaks are by their nature inherently unpredictable, and therefore that the plan should be applied to non-influenza pandemics. But there was no development of that thinking, was there, in the plan? There was no debate about what those inherently unpredictable characteristics might consist of, the differences in the transmission rate, or viral load, or severity, or incubation period. That's correct, isn't it?
That is correct. That said, and I obviously I'm not a scientific clinical expert in any way, shape or form, but it may have been difficult to capture the range of possibilities that you've just alluded to there in a single plan. I think the other point I would make about the utility or otherwise of plans, had the flu plan been reviewed and turned into something that was looking at pandemics or the potential pandemics more widely, whether that plan would have served its purpose would have depended on the capabilities that lay underneath that plan. So I'm straying slightly perhaps into future modules here, but for me the questions in my mind, literally every day, are not so much did we lack a plan, but did we lack the capabilities for dealing with a pandemic of the nature of COVID-19? And obviously I'm talking there about contact tracing, testing infrastructure in particular.
But you would accept, Ms. Sturgeon, that had the plan focused more plainly, more clearly on the inherent unpredictability of viral respiratory pathogens and their characteristics, and identified that the next pandemic might have different characteristics to influenza in terms of transmission rate, incubation period, viral load, severity, it is likely there would have been a much closer and clearer debate about the necessary countermeasures. For example, mass diagnostic testing, mass contact tracing, social restrictions, quarantining, and so on. And that debate was wholly absent, wasn't it, from that strategy and from all the contemporaneous material?
Much of that, yes, was absent from that. So I do think that is fair. And yes, with retrospect and in hindsight, I think we would all have benefited from much earlier discussion around some of these things. I suppose the only point I'm making, maybe this comes from too many years in government, not now, obviously, is I think there is a real danger in putting an overemphasis on plans. There is often a tendency in government to say, well, we have a plan, it sits on the shelf, and so we've done the preparation. And it's what, as I think you're putting to me fairly, it's what lies underneath that. And had there been a plan that looked at the range of pandemics other than flu, then yes, it is possible that we would have had greater discussion around some of the elements that, of course, came very much to the fore when COVID struck.
The reason I put the question to you, Ms. Sturgeon, the way that I did, was to respond to your suggestion that the acknowledged strategic flaws in the plan may not have mattered because what matters more is capability.
Absolutely.
My point to you is, had there been a proper development of the issues of the required countermeasures necessary to meet properly identified risks of non-influenza pandemics in that document, that capability is likely to have been better developed by the time COVID struck?
I think that is fair, and I would accept that. I think it would come down to how precise some of those other predictions or models had been. But I think that is a fair comment to put to me.
And your point about the danger in government of selecting a plan in the reasonable expectation that it will do what it says on the tin and it will meet the need of the exigency or emergency which has arisen. Would you agree that that plan tended to focus upon managing the catastrophic consequences of a pandemic influenza as opposed to trying to prevent those catastrophic consequences from developing in the first place?
I'm not sure I do entirely agree with that. And again, I'm perhaps straying from your question being anchored in the flu preparedness plan and projecting a little bit to some of the commentary that's been made around the handling of COVID. I suppose, there is a question in my mind in the context of a pandemic, what do we mean by prevention? I think there is a question about whether any single country at a population level could prevent, i.e. stop a pandemic happening. Clearly there are measures at an individual level that people try to take to prevent themselves getting it. But in the context of a pandemic, it is, and I can only speak for myself and the Scottish Government here, it was never the case when COVID struck that we just accepted as a given that a reasonable worst-case scenario was going to unfold. It was our determination from the outset to do everything we could, and I think this is what prevention means in the pandemic context, to suppress it to the maximum. The questions I think that are really important for us all to consider, very, very frankly, is could or should we have done more to suppress to the maximum COVID? But speaking on behalf of the government I led at the time, it was never the case that we simply accepted there is a level of harm that is going to be done by this virus, and we accept that. We were always, in fact, it became later on one of the points of difference between the Scottish and the UK government, the extent to which we were still seeking to suppress as opposed to live with the virus. So I don't accept that there was ever, certainly in my mind, an acceptance of a level of harm that we were willing to have unfold.
That was not, however, my question, Ms. Sturgeon. My question revolved around the strategy and whether you accepted that one of the unintended consequences of that strategy was that it tended to focus administrative concentration on trying to deal with the consequences of a catastrophic emergency rather than preventing it in the first place. For example, you've already acknowledged that the absence of thinking on the two main methods by which catastrophic consequences can be prevented, mass diagnostic testing and mass contact tracing, were wholly absent from this strategic debate.
So forgive me if you thought I wasn't answering your question. I was seeking to try to answer your question, but I perhaps went on to COVID more than the flu plan. I think one of your questions, which is reasonable, is the flu plan was looking at flu. And so some of what would have been perhaps in that plan, had it been looking more widely, was not there. What I was seeking to address was this notion, either in the flu plan or later in COVID, that there was simply an acceptance of a level of consequence. I think, forgive me, I can't remember the precise text in the 2011 flu plan, but I think there is commentary in it that reasonable worst-case scenario are not necessarily things you accept. They don't take account of the countermeasures that you take to try to reduce that. So either in that plan or in the eventual handling of COVID, speaking from my own perspective, it was not simply here's a level of consequence that we accept that we can't do anything about. I do think, and this goes to your point about mass testing and contact tracing, the question, very legitimate, is could or should we have done more to put ourselves in the ability of suppressing? It is also the case that I don't think for any responsible government it can ever in a context like this, be either trying to suppress or dealing with the consequences. You have to do both, and that is a feature of the planning as well.
I'm going to put that over to Module 2A, Ms Sturgeon.
Forgive me.
But in relation, therefore, to the strategy, we appear to be agreed that the strategy, because it proclaimed its ability to be applicable to non-influenza pandemics, or whilst it proclaimed its ability to be flexible and applicable to non-influenza pandemics, simply did not provide the thinking or the tools necessary to be able to deal with them. I'm not asking you again about, and I'm not seeking your answer in relation to how the Scottish Government did respond and what its approach was once it was struck by the pandemic, but in terms of the strategizing, the planning and the preparedness at an overarching level, that thinking and the development of the necessary tools was absent from the sole strategy document that was meant to be applicable.
I think that is fair, yes.
Right.
We're going to be break. I'm sorry, we have to take
yes.
a break every so often, Mr. Sturgeon, for the stenographer. Would that be a suitable?
Very suitable, thank you, my lady.
Right, I shall return at 11:30.